Thanks, Lily, for this opportunity. So this is just a clinical experience sharing of a patient on Abemaciclib. So this basically is a 50-year-old lady who was postmenopausal. She presented with a right breast lump of 1 month duration. Biopsy showed it as IDC grade 2. It was T2N1M0. ER positive, PR negative, HER2 negative, and Ki67 was 70%. It was grade 2. So this patient actually underwent a BCS followed by standard chemotherapy, followed by radiation, and she was on letrozole. 1.5 years into letrozole, she presented with back pain. Clinical examination showed a right supraclavicular lymph node, and she had bony tenderness along the thoracic spine. PET scan showed extensive lytic sclerotic lesions involving the appendicular and the axial skeleton, right axillary and supraclavicular nodes, and some external iliac lymph nodes on the left, which we could not place exactly what it was due to. Supraclavicular lymph node biopsy showed IDC grade 3 this time, ER positive, PR and HER2 negative, and Ki67 was 45%. So basically a postmenopausal lady treated with adjuvant treatment for a stage 2 disease, now presenting with bone metastasis and lymph node mets. It is a grade 3 disease and PR is negative with a high Ki67. So when somebody presents with metastatic breast cancer, we look for characteristics which will tell us what could be the prognosis. There are some good prognostic factors, and then there are some factors which tell us that this patient is likely to do poorly. Now, those factors which suggest that patient will do poorly are a shorter time to recurrence from early stage. Generally, less than 2 years would suggest some form of endocrine resistance, presence of liver and other visceral metastasis, a high-grade tumor like our patient, and patients who are PR negative. So progesterone receptor negative, a high-grade tumor, presence of visceral mets, especially liver mets, and a short time to recurrence. Now, these are the kind of patients who were put in the Monarch 2 study. So Monarch 2 study was designed for patients who are hormone receptor positive, HER2 negative advanced breast cancer, who are pre or perimenopausal, but predominantly they were postmenopausal, and who had endocrine therapy resistance. So the definition of endocrine therapy resistance was patients who relapsed while on adjuvant therapy or within 12 months of completing adjuvant therapy, or patients who have progressed on first-line endocrine therapy. No chemotherapy should have been given for advanced breast cancer, and no more than one type of endocrine therapy. So they were randomized in 2:1 fashion to Abemaciclib 150 mg 2 times a day on a continuous schedule with fulvestrant standard dosage compared to a placebo plus a fulvestrant treatment. The primary endpoint was a progression-free survival, multiple secondary endpoints, especially overall survival and safety, and some exploratory endpoints. Now, if you look at the progression-free survival, which was updated recently, you can see that compared to 2017, the PFS seems to be holding on. So the median PFS is around 16.5 months for Abemaciclib plus fulvestrant, compared to around 9 months to fulvestrant alone with a hazard ratio of 0.5. So an excellent benefit with a combination of Abemaciclib with fulvestrant. So if you look at the different subgroups, it is highlighted here that patients with the endocrine therapy resistance, PR negative, and visceral metastasis actually did better. If you look at the endocrine therapy resistance alone, primary resistance did come much better compared to patients with secondary resistance. What about the overall survival? So at the interim analysis, the overall survival compared to placebo was around 9 months better when you added Abemaciclib to fulvestrant. So it improved from a median of 37 months to nearly 47 months. Even the overall survival, there was significant benefit for patients with visceral metastasis and patients with primary resistance. So what is this primary resistance? Primary resistance are those patients who relapse while on the first 2 years of adjuvant endocrine therapy or progress within the first 6 months of treatment for metastatic breast cancer. So these are primary resistant patients. So if you look at our patient, she progressed 1.5 years into adjuvant therapy. So this patient, really fitted into this Monarch 2 study, and she was started on Abemaciclib 150 mg BD and fulvestrant. First 2-3 doses were 500 mg every 15 days. Then patient received monthly doses. Of course, she received zoledronic acid also. So the early experience is that, within 15-20 days, patients had significant improvement in terms of symptoms. The back pain settled down. We noticed a mild increase in creatinine and no other significant toxicity. So this increase in creatinine is quite interesting. We know that increased creatinine can generally mean a problem with the GFR, that is the glomerular filtration rate. But in Abemaciclib, it is not the GFR which is abnormal. What happens is the tubular secretion of Abemaciclib in, of creatinine actually is compromised, and hence the creatinine rises mildly. If you look at the Monarch 1 and 2 study, most of them, so you see that 98.5% of patients in Monarch 1 and 98.4% patients in Monarch 2 had an increase in serum creatinine. And how much was the increase? Median was 0.24 to 0.3. So this increase in serum creatinine has some implications. One of the consequences is many of our patients are on metformin for hyperglycemia, and metformin actually, the elimination of metformin is through the same pathway, and metformin seems to be working suddenly better when you start this drug. So what you have to be careful is look for a further increase or a progressive increase in serum creatinine, because most of the time the increase in serum creatinine is mild and it remains there for a prolonged period of time. It doesn't progressively worsen. If that happens, or there are other indications of renal injury like proteinuria, it is better that you get a nephrologist into the picture. So these are few photographs of this patient. The first one is in May 2021, the second in August 21, and the third one is May 2022. And you can see progressively significant decrease in the FDG uptake in the bone metastasis. Same here, you can see a large pelvic deposit, which is healing very well. Multiple spine mets, which are healing well. And these are clearly seen in these 3 photographs, where there is significant benefit and significant improvement in these patients. So here I have presented a relatively young lady, a 50-year-old lady with extensive bone metastasis, who progressed within 1 year or 1.5 years of adjuvant letrozole and treated with Abemaciclib with fulvestrant with quite a good response. So shall we go to the next part of it, where I will involve Dr. Shivam, a consultant medical oncologist at SL Raheja Hospital.
Thank you, Dr. Krishna, for a lucid talk, and I was very interested in listening to your case. Especially this creatinine part, we have seen in our practice that only mild increase is there. And sometimes when we go back and look at the drugs, there are some drug reactions, ACE inhibitors or these metformins that we need to change. And then these patients reverse. Very interesting point that you brought up, sir.
So, Shivam, if I can get you into this, so now we have 3 CDK4 inhibitors. What could be the differences, and do you think that inhibition of CDK4 compared to CDK6, is there any differential inhibition, and does this really affect the choice which you make?
Sir, in theory, there is indication that some CDK4 inhibition is preferred by one drug as compared to the other. But whenever we look at the clinical trial data, this does not reflect in the clinical trial data. So as of now, this does not have any implication in my practice. We do see that this has different impact on the side effect profile of a drug. But again, across all trials, all drugs have shown different side effect profile, and it has really not been beneficial to go by this method.
Fair enough. I think so. Probably the only implication, like you have pointed out, is in terms of side effects. We know that Abemaciclib really works 14 times more on CDK4 compared to CDK6. This differential is much more than the other two CDK4 inhibitor. CDK6 inhibition actually is the one which results in cytopenias, and probably that is the reason why we have less of cytopenias with abemaciclib. But I think, Shivam, you put it right across that most of the time there is not much implication. But if somebody already has a little bit of cytopenias, you would probably be inclined to select something which has lots of CDK6 inhibition. So the next question is, how important is the overall survival benefit? Does it come to your mind that you need to think about this, or are you comfortable with just seeing a PFS benefit?
So overall survival is very important in my practice. But when we see different trials of three different CDK4 inhibitors, different drugs have shown different overall survival. I try to focus on HR ratio, and Abemaciclib here has shown a significant improvement in the HR in Monarch 2 trial with a 0.454 hazard ratio. So for me, hazard ratio in overall survival is more important as compared to PFS alone. There is no cross trial, there is only cross trial examination, but these drugs were never head on. So that is not impacting my practice as of now, sir.
Fair enough. I think it is pretty clear that abemaciclib has a good overall survival benefit. And when you're looking at choice of CDK4 inhibitors, most of them are showing some survival benefit. And of course, there is some interesting data on how you interpret some of these trials. So when you put patients on abemaciclib plus hormonal therapy, does it cross your mind that you are trying to delay the initiation of chemotherapy in these patients? Why I'm asking is many of our patients really cannot afford these drugs, and I was surprised to know that even in the US at present, around 20% of the patients cannot afford this and are given first-line chemotherapy in a hormone receptor positive MBC.
I think this concept is changing. We in Bombay at least are not practicing chemotherapy in hormone positive metastatic breast cancer. There are support groups. One of the CDK4 inhibitors have a support group, and the drug is going to become cheaper. Patients, when they hear about a cost of a monthly therapy of a 70,000, and in our private practice, chemotherapy would also cost almost the same amount, coming into the daycare session twice in a month, and the CBC and everything associated with it. Most of the patients are now preferring for CDK4 inhibitors. I am not giving chemotherapy in hormone positive metastatic breast cancer as of now. Even if patients are not affording, trying to find out a method, or they're not in visceral crisis, giving them only hormone therapy and waiting for the CDK4 inhibitors to become cheaper. So as of now, no chemotherapy in hormone positive metastatic breast cancers.
Yeah, I think a fair enough point. Ideally, most of these patients or all of these patients who are strongly hormone positive and not in visceral crisis should actually get a CDK4 inhibitor with hormonal therapy. Shivam, your thoughts that there are some papers now, even in visceral crisis, where they have tried CDK4 inhibitors?
Sir, in my opinion, the definition of visceral crisis needs to be revisited, especially in the CDK4/6 era. Uh, Evidence of liver metastasis without overt jaundice, or pleural metastasis without pleural effusion, or a effusion that can be drained and is not rapidly filling. I think these patients do very well with CDK4 inhibitors because the median time to response is close to 4 weeks, 4 to 6 weeks. So I think definition needs to be revisited, sir. And even in visceral crisis, present definition, patient is fit and stable. I rather prefer to start them on CDK4 inhibitors than chemotherapy, which is more toxic.
Fair enough. I think nicely put, Shiva. So, so if somebody has liver metastasis, Shiva, would that be a changer for you in terms of selection of CDK4 inhibitor?
So, liver metastasis in our practice that we have seen is a poor prognostic marker for survival benefit. So I think with Monarch 2 data, especially with the graphs that separated for liver metastasis, we could see that abemaciclib had a better response and a good response in patients even with liver metastasis, and there was a OS benefit. Also, I like the fact that the drug is a continuous usage rather than a breakage, because the breakage is primarily because of cytopenias. Now, if a drug does not have cytopenias, you're able to give abemaciclib throughout the month, throughout the therapy. So I prefer to choose patients with poor prognostic markers. Abemaciclib is my first choice because continuous infusion of the drug and no cytopenias.
Fair enough. So continuity of the drug probably helps in getting more of the CDK4 inhibitor. And that is where probably a differential inhibition of CDK4 probably has a role to play. So does the endocrine resistance status of the patient impact on abemaciclib usage or use and choice of abema?
Sir, I think it just determines the background hormone deprivation that I'm doing. So primary endocrine resistance, we tend to use fulvestrant more, look at these patients for ESR1 mutation. Uh, Secondary endocrine resistance, depending upon which anti-hormone therapy they were on. But as of now, based on Monarch 2 trial data, I'm using fulvestrant and abemaciclib in most of my patients who are upfront metastatics.
So when we look at the clinical trial data of Monarch 2, it is pretty clear that patients with the endocrine resistance did pretty well when you added abemaciclib. This is in contrast to the trial data, I think, from Paloma 3, where palbociclib actually did not show benefit when added to patients with endocrine resistance, and only patients who had some sensitivity to endocrine therapy actually benefited from palbociclib. So it was very clear that patients with an aggressive disease where abemaciclib showed clear benefit, palbociclib did not. Also, the fact that even when, if you look up patients with these poor risk, that is endocrine resistance, there again, primary endocrine resistance really benefited from abemaciclib, probably telling us that abemaciclib is a pretty strong drug in terms of overcoming this endocrine resistance.
One of the other factors is that the reason for primary endocrine or primary chemotherapy resistance is also PI3K mutation. So what we also saw in the sub-analysis of the group, that even with PI3K mutation, the drug was working. I think this could be one of the contributory factors that abemaciclib was scoring, comparatively better than the other CDK4s in the same group.
Yeah, fair enough. So I think you touched upon this, Shivam, importance of continuous dosing. So which are the kind of patients where you say, okay, this patient really requires a continuous dosing?
So generally, I am choosing abemaciclib based on two factors. One is patients who are likely to have cytopenias, elderly patients, and poor marrow reserve. So they do well with abemaciclib-based treatment in my practice. And outstation patients, sir, it's easier for them to explain to them the usage of the drugs. And I don't want them to have cytopenias, come back into the OPD at 7 days, 28 days, and then subsequently. So these are the patients who are ideal in our practice. More and more usage is increasing, so we are finding this drug easily, usable.
And Shivam, there are quite a few data points now to suggest that even patients with brain metastasis, abemaciclib has a quite good response. Your comments on that?
Sir, this was very clear when the subgroup analysis, because the brain metastasis patients were allowed in Monarch 2, and then we could see that there was some response of the drug in the brain metastasis also. The brain lesions remained stable, and it led to an improvement in the overall survival. So I think this is the only CDK4 inhibitor that we now know has some activity in the brain with definitive activity. Uh, Although hormone positive cancer, in my opinion, does not travel much to the brain. Uh, I don't have much patients who have brain metastasis overtly at presentation. They would develop brain metastasis quite down the line, and now Abema is being used earlier. So we don't have much patients in our practice, but yes, there is proof of concept that this drug has a good penetration into the CNS.
Fair enough. So if I understand right, most of your patients now who progress on endocrine therapy would end up with a CDK4 inhibitor plus probably fulvestrant if they were on aromatase inhibitors. And for especially patients with poor prognostic factors like liver metastasis, brain metastasis, who have got a rapidly progressive disease, high tumor burden, your choice probably would end up with abemaciclib. Is that right?
I think so, sir. That's the right way to put it. This is what the practice is present.
Fair enough. Now, finally, coming to the side effect profile. So, what is your experience with diarrhea been?
I think, sir, this is a question I think which has concerned me also before I started using the drug. I would relate this to S1 as one of the drugs which has no diarrhea in Japanese patients and has a lot of diarrhea in Indian patients. What other day also we were sitting down with a professor from the Saudi that he was also suggesting that there is very least diarrhea seen in their subgroup of population. I think this is also our experience. Indian patients do not have much diarrhea. And even with immunotherapy that we have seen that we are using the checkpoint inhibitors, our patients relatively have much less side effects as compared to what is reported in the West. I think this is to do with the gut biome, the fact that we have a very probiotic diet. We eat a lot of curd. I think this when this is studied in detail, we would understand that diarrhea is not much of a concern in Indian patients. In my practice, I'm yet to get a grade 3, grade 4 diarrhea.
Maybe a chart from childhood, especially in Mumbai, would help a lot. So, I think we have covered most of the points. So I think the experience with abemaciclib in terms of side effect profile has been pretty good. And the diarrhea is what we are worried about. In fact, we give anti-diarrheals with them in hand so that they take it immediately, but it is hardly ever used. So overall, I think abemaciclib is a very well tolerated drug, can be given on a continuous basis, which may probably have an implication in terms of disease control, and it seems to be one of the strongest CDK4 inhibitors in terms of overcoming endocrine resistance. So with that, I thank you for this opportunity, and thanks Dr. Shivam for an very entertaining and enthusiastic
Thank you, Dr. Krishna,
questionnaire.
for this nice talk and for these nice panel that you discussed with me. And I would like to sincerely thank Lily for having us as a part of this and the organizers of the conference. It's a brilliant conference organized. Really enjoyed.
Thank you.
Thank you. Dr. Manish, sir.